Thank you, Dr. Wong, for that amazing talk, and I'm constantly inspired by the work that you do. I was hoping that we would get to see some procedural pictures, because those are always really fun, but before lunch, probably not a great idea for those with a weak stomach, so good call on that one. So I'm going to be talking to you about a initiative that we started at Stanford with Dean Miner's support in pharmacogenomics and precision medicine, and I got a chance to speak with our colleagues at NUS, and they are doing amazing things with preemptive pharmacogenetic testing as well. And as I was introducing myself prior to these talks, I asked an attendee, what would you like to get out of today? And they said, I would like to figure out how to live healthier myself, how to prevent side effects in medications that I take, and how to know that I'm taking the right drug and dose. And so this is what this talk is about. I predict that everyone in this room will get pharmacogenetic testing at some point in their lives. And today we're going to talk about what to look for when you're getting this pharmacogenetic testing. And I always like to ask, before I start, how many people have already gotten genetic testing in this room of any kind? Okay, so a little bit fewer than what I see in Silicon Valley. In Silicon Valley, when I ask this question, about half of the people have gotten 23andMe already, and there's some pharmacogenetics in there. And then I ask, how many have talked about this with their doctor? And no hands go up. I see the few people that raise their hands are shaking their heads. Because physicians are not yet well versed in these topics, and this is going to be important as we move forward in implementing genetic and pharmacogenetic testing, is educating our providers on how to incorporate this data into their clinical care. So I'm going to start with a story, and this is about a patient that I had. The patient is the third over from the right. And next to me is our pharmacist, and at the far end is Megan Mahoney, who was our vice chief of staff. And this was at our big data conference. And this patient needed a surgery, but did not want to get that surgery because whenever she had a surgery, the doctors would give her pain medicines, and they wouldn't work. And she would have all of the side effects of the pain medicines, in this case Vicodin, codeine. She would have constipation, she would get delirium, get a little loopy, but she wouldn't get pain relief. And her doctors thought, oh, well, maybe is she a drug seeker? Does she take drugs outside of here? And because she was asking for more and more drugs and only getting the side effects and not getting any of the pain relief. And so we were able to do pharmacogenetic testing on her and find out that she was an atypical metabolizer of CYP2D6, which is the enzyme in the liver that metabolizes codeine from its prodrug to active drug. So it needs to be cleaved to become active. And she didn't have that enzyme, and that's why that drug didn't work for her. So she was part of our human-wide initiative, again led by Dean Miner. And so you can Google this. She has a video of her post-op day 2 when we were able to give her a different drug to control her pain. And this variant is present in 5% of the population. So the FDA approves drugs when they work for most people, 90% of people. But on the ends of the bell curve, we have people for whom these drugs don't work. And of the variants that we test, the 24 different variants, 90% of people, so I will say 90% of the people in this room, so everyone but 5 people, will have one variant that is important to you for a drug that you will take at some point in your life. So I'm going to talk a little bit about what pharmacogenomics is, give you a little bit of the background of why we do this, because there are many drugs that affect the metabolism. There are many genes that affect the metabolism of our drugs, and we bring this together to look at how our genes can influence the medications you take, and we look at how medications are absorbed and metabolized and processed by your body. So the benefits of pharmacogenomics are to reduce side effects, and I talked in my earlier talk about carbamazepine and the toxic skin reaction. And for doctors, it's useful because we don't have to guess. So antidepressants is a great example. And if you know of anyone in your life that has had to take an antidepressant or an anti-anxiety medication, you know that doctors have to prescribe a medicine. You have to wait for 6 weeks. You have to see what your side effects are. You have to see if your symptoms get better before you try probably another medication. So depression and anxiety is definitely one where pharmacogenomics can be very helpful. And this, because you are getting to the right drug quickly, can save a patient money on medication as well. So as I mentioned, we'll have patients with the same condition, let's say high cholesterol, for instance. And you'll have people who are good responders. Most people are good responders, 90%. But on the ends of the spectrum, we have people who have the bad side effects and then the people who don't respond at all. And it's a small proportion, but we want to find those people because that's when we get from mass medicine to precision medicine. Okay, so most people, for most things, are normal metabolizers. So when I talk to patients, I describe traffic on a highway. You have 2 lanes on a highway if you're a normal or typical metabolizer. If you're an intermediate metabolizer, you only have 1 lane on the highway, which is okay if you're only taking 1 drug that is metabolized by this enzyme. But if you're taking 2 drugs, you can get a traffic jam, you can get high levels of one of the drugs, and you can get toxic side effects. And then there are rapid ultra-metabolizers that have 3 lanes on the highway, so they're clicking through the drug very quickly. So I'll use an example of codeine. So when you're taking codeine, you're moving quickly to its active form, morphine, and then in this way you get more respiratory depression, which is a bad side effect, and you get pain relief, but you only get it for 15 minutes, and then you need more morphine quickly, and this can be difficult to dose. And then there are poor metabolizers. This is a picture of Devil's Slide, and people who are poor metabolizers don't click over to the active drug at all. And so these atypical metabolizers make up about 10% of the population. Next slide. And as I mentioned, decisions around Asian health are mainly made using non-Asian data. So I showed you in the genomic databases, 80% are European. Asians are underrepresented by a factor of 4 in genetic data. So all the pharmacogenetic variants that I'm telling you about have mainly been studied in European populations, and so we need more research on Asian populations to find unique variants in Asian populations. Okay, so this is a case study of a patient that my colleague and co-founder Bryant Lin had, 74-year-old man with gout. And this is a drug that is still commonly prescribed here in Singapore for gout, allopurinol, very commonly prescribed, first line in the United States. And the patient developed a toxic skin reaction called DRESS, so it's a sloughing of the skin. And on the FDA label, allopurinol is considered a very safe drug, and there was no mention of the increased risk for certain subgroups with this HLA variant that is more common in Han Chinese populations. So this is why at Stanford, when we have patients, 1 out of 3 who are Asian, and we don't have the guidance of differences in Asians, that we're frustrated and want to increase research in these areas so we can provide medical clinical care. So this is a lot of graphics, and I just want to give you sort of whet your appetite for the pharmacogenetic differences that we already know about in Asians, and there's many, many more that we still have not yet discovered. So statins is a drug that's commonly taken. About half of adults take statins to lower their cholesterol. And there's differences in the OAT-P1B1 receptor in the liver cells that are transcribed by SLC01B1, and a lower dose is recommended for Asians for some of these cholesterol-lowering drugs. Similarly, for clopidogrel, which is a drug that we give to prevent clotting after heart attacks, there's differences in CYP2C19 with a loss of function mutation that is present in 1 out of 4 Japanese, 1 out of 7 Koreans, 1 out of 10 people who are Chinese, that causes increased risk of thrombosis. So you're giving a drug to prevent clotting, and yet there's more clotting in these groups because of this difference in CYP2C19. And then in Asian Indians, 1 out of 4 have increased risk of bleeding. And incidentally, this was the drug that was given to my father after he had a heart attack, and his clot initially opened, but then he had this toxic side effect that caused a massive bleed and led to his demise ultimately. And then warfarin, which is a drug that we give to people with atrial fibrillation and arrhythmias. There's differences in CYP2C9 and also VCORC-C1 that recommend decreased dosing for Chinese, Japanese, and Korean, and increased dosing for other groups. And again, this is just the tip of the iceberg for what we know for pharmacogenetic differences in Asians. And this is something that we can all work together by participating in clinical trials, sharing our data in terms of electronic health records to find these new variants so that we can provide better prescribing going forward. So the prevalence of HLA-B5801 is much more common in Asians, about 10% of Asians. And the risk of allopurinol-associated severe cutaneous adverse reactions are 3 times more likely in Asians. And this is not something that is on the label for this drug, and that is what we hope to work for at CARE, to increase knowledge of this so everyone who's prescribing this drug knows about this increased risk.